Good morning. We want to say welcome to our Grand Rounds presentation this morning. We want to say welcome as well to our viewers on internet. What you're going to be experiencing this morning is hearing some of our first-year medical students make formal presentations in a Grand Round format. These students have worked very hard. This is part of their medical informatics course that they received during their first year. These cases have been taken from the case records from Massachusetts General Hospital as published in the New England Journal of Medicine. So these students will be making formal presentations by presenting their history, the pertinent physical findings, as well as a diagnosis and a differential diagnosis. Then they'll take you into aspects of research, obviously treatment, OMM if indicated, as well as the ethical components to the cases. The cases will be focusing at this session on reproductive elements of the section that they've just completed, as well as endocrine aspects of the curriculum that they've just completed. So our first case is a young lady, a young girl with an enlarging neck mass, and we'll go ahead and turn it over to the doctor.
Thank you, Dr. Johnston. Well, good morning. Thank you all for coming to our presentation of a 13-year-old girl with an enlarging neck mass. It was published in the New England Journal of Medicine as a case record from the Massachusetts General Hospital from 2010. We are Group 19, and here are the members of our group. My name is student Dr. Stephanie Meyer, and I will begin with the clinical presentation of our patient, a 13-year-old girl. 8 days before referral to the Pediatric Endocrinology Clinic at Massachusetts General Hospital, she began to notice swelling in her neck and pain upon swallowing, otherwise known as odynophagia. 2 days later, she was seen by her primary care physician, who noted an enlarged thyroid. And the thyroid is a gland which sits anterior to the trachea and inferior to the larynx. It's got two lobes, a right lobe and a left lobe, that are connected by an isthmus. And it is a player in synthesizing hormones that regulate your metabolism. At this time, her blood was taken and she was referred to the Pediatric Endocrinology Clinic. When she was seen in the clinic, our patient reported tightness in her neck and some nausea. She had not experienced difficulties with breathing or swallowing and reported no feelings of being hot or cold. She also denied experiencing changes in her appetite, level of thirst, weight, energy level, or any musculoskeletal symptoms. She also denied experiencing changes in her hair, skin, nails, and no skin lesions. No vomiting, diarrhea, constipation, or urinary frequency were reported. Our patient's past medical history was pretty easy. She was carried to term and was delivered without any complications. For her, menarche occurred at 9 years of age, and her menstrual cycle had normalized recently. Her last menses was 16 days prior to her visit to the Pediatric Endocrinology Clinic. She did report migraines, which occurred approximately once a month, and 1 or 2 headaches each week that did not disturb her sleep cycle. She was not on any medications except for over-the-counter analgesics, which she took for her headaches as needed. She had no known drug allergies. And she lived with her parents and 2 siblings, and it is important to note that our patient has a history of hypothyroidism in her family on her mother's side, with her mother, maternal aunt, grandmother, and cousin being diagnosed with hypothyroidism, and her mother had recently developed a thyroid nodule that was being evaluated. The patient's physical exam findings are shown here. She did not appear ill upon entering the room, and her blood pressure and pulse were normal. Her height was in the 77th percentile, and her weight was in the 88th percentile. Her BMI was 22.6. No exophthalmos was observed, and her extraocular movements were normal, but importantly, her thyroid was firm with a detectable mass on the left lobe. The right lobe measured 4.5 centimeters at its greatest dimension, and the left lobe measured 6.5 centimeters at its greatest dimension. And the left lobe was also rotated more laterally when compared with the right. The figure on the screen shows common measures taken of thyroid. We will be focusing on the longitudinal measure of each of the lobes, which are typically the largest measure. At this time, because of the physical exam findings in the endocrinology clinic and our patient's blood panel results from her primary care physician, she was prescribed levothyroxine, a synthetic form of T4. Here are the lab results from our patient's blood panel that she received from her primary care physician. The measures in red show the elevated levels in our patient. Her serum thyrotropin was elevated, as well as antibodies toward thyroid peroxidase and thyroglobulin. Serum thyrotropin, or TSH, is secreted from the anterior pituitary in response to thyroid-releasing hormone from the hypothalamus. TSH acts on the thyroid gland and prompts it to synthesize and secrete thyroid hormones T3 and T4 into circulation. T3 and T4 levels then feed back to the anterior pituitary and inhibit the release of thyroid-stimulating hormone. Our patient formed antibodies to thyroid peroxidase, here, and thyroglobulin, here, which are major cofactors in the synthesis and secretion of T3 and T4. So T3 and T4 levels in our patient are low, inhibiting, or decreasing, the negative feedback mechanism you see here, which would increase the amount of thyroid-stimulating hormone our thyroid will receive. And thyroid-stimulating hormone has a trophic effect on the thyroid, meaning that it makes it larger. So our patient was prescribed levothyroxine, a synthetic form of T4, to bring the thyroid levels back to normal, decreasing TSH, and decreasing the size of our patient's thyroid. However, 15 days later, after her initial visit to the pediatric endocrinology clinic, our patient's mother called because the thyroid of her daughter was increasing in size. The next day, ultrasound was performed on our patient, and the findings revealed a diffusely enlarged thyroid gland, with the left lobe measuring 5.9 centimeters at its greatest point and the right lobe measuring 5.1 centimeters at its greatest point. Heterogeneous parenchyma was also observed, and this is a nondescript finding that is associated with conditions that diffusely affect the thyroid. Lymph nodes were also found on either side of the thyroid, lateral to both common carotid arteries, posterior to the left clavicular head, and an enlarged lymph node was also found lateral to the left common carotid artery, with echo texture resembling that seen in the thyroid. So in panel A, you have a transverse section through our patient's right lobe of her thyroid gland. Between these two arrowheads is what would represent normal thyroid tissue. It is homogeneous, and you don't see any hyperechoic foci. At the tip of this arrowhead, you see like a bright white spot, and then those bright white spots are hyperechoic foci, and they increase as you move superiorly in the image. Panel B shows a sagittal section through the left lobe of our patient's thyroid. At the tip of each of these arrowheads is a hyperechoic foci, and you can see that they are diffusely dispersed throughout our patient's left lobe of the thyroid. Importantly, panel C shows a sagittal section through the lymph node found lateral to the left common carotid artery. Between the four arrowheads, you see the hyperechoic foci and the heterogeneous parenchyma that looks very similar to what we see in the thyroid. This is indicative of a disease process in the thyroid now spreading to lymph nodes in the area. The hyperechoic foci I've been referring to are microcalcifications called Samoma bodies. They are most commonly observed in papillary thyroid cancer. This is a histologic stain showing what a Samoma body looks like up close, and the stain is not from our patient. 9 days later, our patient had a repeat physical and reported no pain during swallowing, no hoarseness, difficulty breathing, or weight fluctuations. The thyroid was again firm to palpation and had increased in size again, where the right lobe is 6 centimeters and the left lobe is 7 centimeters. So 24 days prior, in 24 days, our patient's right lobe had increased 1.5 centimeters in size, and the left lobe had increased 0.5 centimeter in size. Small cervical lymph nodes were also palpable at this time. The table on the screen shows the standard measures of what is considered normal and enlarged for an adult thyroid. Since we're focusing on the longitudinal length, this highlighted in red. Even though our patient is a pediatric patient, you can see that her measures clearly state that her thyroid is enlarged. An enlarged thyroid is often called a goiter, and a goiter is a presentation of different types of thyroid disease. At this time, a fine needle aspiration was performed, and this procedure entails using a 23 to 27 gauge needle to pierce the skin into the tissue of interest. In our patient, it was her thyroid. The plunger in the syringe attached to the needle is then pulled to create a vacuum, which pulls some of the tissue up into the needle. The sample is then placed on a slide for staining and cytologic evaluation. I will now introduce student Dr. Nguyen to discuss the differential diagnosis.
Thank you, student Dr. Meyer. Hi, I'm student Dr. Harrison Nguyen, and I will be presenting the differential diagnosis for our patient. Here we have listed the congenital and acquired causes of enlarged thyroid. We will go through each disease and come to a final diagnosis at the end. We will start with the thyroglossal duct cyst. So the thyroglossal duct is an epithelium-lined connection between the foramen cecum and the thyroid gland. The thyroglossal duct cyst formed from leftover tissue during thyroid development. In this figure, this is a supine person. Here's the nose, the mouth, and the neck. The cyst can occur anywhere along the thyroglossal duct tract. However, our patient's thyroid mass is firm and not cystic. It is also important to note that thyroglossal duct cysts typically present at the midline of the neck, whereas our patient has bilateral enlargement. Dyshormonogenesis is characterized by an absence or insufficiency in thyroid peroxidase enzyme. As you can see in the figure, a defect in thyroid peroxidase will lead to a decrease in thyroid hormone circulation. This presents as progressive goiter and hypothyroidism. However, this is unlikely in our patient because it is tested for at birth and our patient has a rapidly enlarging thyroid with autoimmune involvement. This makes both congenital forms of enlarged thyroid unlikely in our patient. Colloid goiter is associated with normal thyroid function and no antibodies. Causes of colloid goiter include the inability of the body to keep up, or the inability of the thyroid to keep up with the body's metabolic demands, or iodide deficiency. As you can see in this chart, our patient had significantly elevated antithyroid peroxidase antibodies and antithyroid globulin antibodies, making colloid goiter unlikely in our patient. Goitrogens and iodide deficiency both have to do with the patient's diet. Goitrogens are foods that interfere with iodide uptake at the sodium iodide symporter. Iodide deficiency can cause congenital hypothyroidism, which is also known as cretinism. This is very rare in the United States. Since our patient did not present with an abnormal diet or fad diet, both goitrogens and iodide deficiency are unlikely in our patient. Colloid goiter, goitrogens, and iodide deficiency are all unlikely in our patient. Subacute granulomatous thyroiditis, also known as de Quervain thyroiditis, is a form of inflammatory thyroid disease. It presents as a triphasic clinical course, starting with hyperthyroidism and fever, then hypothyroidism, and then euthyroidism. The hyperthyroidism occurs because the follicular epithelial cells rupture, causing all the stored thyroid hormones to be released into the bloodstream. Hypothyroidism ensues 2 months later because the follicular cells are needed to synthesize thyroid hormones. And then in about another 2 months, when the follicular epithelial cells regenerate, 95% of the patients return to euthyroidism, which is normal thyroid function. This usually follows viral infection and is associated with pain and fatigue. However, this is unlikely in our patient because she did not present with pain or significant fatigue, her CBC was normal, and it is also very rare in children. Acute suppurative thyroiditis is another form of inflammatory thyroid disease. Presents as painful thyroid infection and occurs unilaterally 90% of the time, involving the left lobe. This is very rare because of the high iodine concentration in the thyroid gland, the ample blood supply and lymphatics, and the isolation of the thyroid gland from other important neck structures. Also, she does not present with signs of infection such as leukocytosis, painful swelling, or fever. This makes both inflammatory thyroid diseases unlikely in our patient. Thyroid nodules and thyroid cysts are not of immediate concern because our patient's mass is diffusely large and firm in nature and not nodular or cystic. This makes thyroid nodules and thyroid cysts unlikely in our patient. Chronic autoimmune thyroiditis, also known as Hashimoto's thyroiditis, is marked by anti-thyroid antibodies to thyroglobulin and thyroid peroxidase. These antibodies will cause a decrease in the amount of T4 and T3 in circulation. Because of the decrease in T4 and T3, the thyroid gland will not be able to negatively feed back onto the anterior pituitary. This will cause an increase in the amount of TSH. The increase in TSH is responsible for the trophic effects of the thyroid. Hashimoto's is also the most common thyroid disorder in the pediatric population. This makes Hashimoto's a likely diagnosis for our patient. Here are some genetics involving Hashimoto's. It is important to note that these were not observed in our patient. The human leukocyte antigen DR3 is an allele involved in the interaction between an antigen-presenting cell and a T cell. Faulty interaction predisposes the individual to Hashimoto's. Regulatory T cells are cells that are involved in suppressing autoreactivity in the body. Mutations in either FOXP3 or CTLA4 can predispose an individual to Hashimoto's. FOXP3 is a transcription factor on the X chromosome, and it is involved in differentiating naive T cells into T regulatory cells. CTLA4 protein is a membrane receptor protein that acts as an off switch when it interacts with antigen-presenting cells. As you can see in these pictures, when CTLA4 interacts with the antigen-presenting cells, it inhibits T cell activation, and it also prevents other T cells from interacting with the antigen-presenting cell. It is also important to note that more women than men have Hashimoto's thyroiditis, which suggests a role in the X chromosome. Additionally, more older women than younger women have Hashimoto's thyroiditis, which suggests a correlation with estrogen levels. Since our patient is expected to have Hashimoto's, levothyroxine treatment was administered. With the increase in T4 and T3 from levothyroxine, it should be able to negatively feed back on the anterior pituitary and reduce the amount of TSH secreted. The reduction in TSH is supposed to decrease the thyroid size. However, our patient's thyroid continued to increase in size. This is a biopsy taken from our patient. This arrow points to a large germinal center. These three arrows point to psammoma bodies, and this arrow points to lymphovascular infiltration. So here are some patient indications for thyroid cancer. She has a rapidly enlarging gland, dysphagia, continued growth despite levothyroxine treatment, chronic autoimmune thyroiditis, and Samoma bodies seen on the fine needle aspiration. Here are some thyroid cancers, but we will be focusing on the papillary thyroid cancer, the diffuse sclerosing variant. So papillary thyroid cancer accounts for 80% of all thyroid cancers and is the most common thyroid cancer seen in the pediatric population. The diffuse sclerosing variant is marked by more aggressive tumors and a higher rate of metastasis. Follicular thyroid cancer is the second most common and is seen in people aged 40 through 60. However, it does not have a high rate of metastasis. Medullary thyroid cancer is cancer of the parafollicular cells, which is involved in secretion of calcitonin, not thyroid hormones. It is seen in patients with multiple endocrine neoplastic syndrome. Large B-cell lymphoma is a type of non-Hodgkin's lymphoma, but our patient had normal CBC. Anaplastic carcinoma accounts for only 1% of all thyroid cancers, but is the most deadly. It is seen in patients aged 65 and older, and most do not live 1 year from the day they are diagnosed. Our final diagnosis is diffuse sclerosing variant of papillary carcinoma with metastasis to the left cervical lymph node associated with Hashimoto's thyroiditis. And these stats show that this is a rare combination. In patients aged 10 through 14, papillary thyroid cancer occurs in only 0.44 people out of 100,000. And out of the papillary carcinomas, the deep sclerosing variant accounts for only 1.8% of them. And then in Hashimoto's, patients aged 11 through 18 are estimated to occur in only 1.3% of the people. I would now like to introduce student Dr. Merrill, who will be covering the treatment, emerging research, and bioethical considerations.
Thank you, student Dr. Wynn. I'm student Dr. Merrill, and will be discussing the treatment, emerging research, and bioethical considerations for our patient who's recently been diagnosed with thyroid cancer. Before talking about our patient specifically, I would like to talk about the typical management of general thyroid cancer, as our patient will follow similar steps. This starts with a thyroidectomy. This is either a partial or by lobe, or a total thyroidectomy. Associated with this is a resection of any affected lymph nodes. This is to stage the disease. Next, patients undergo radioactive iodine therapy. This is to ablate any residual thyroid tissue remaining in the body. Antithyroid medications are then started, or more commonly continued, to be able to inhibit any thyroid hormone production. These medications include perchlorate or thiocyanate, which medications act on this part of the diagram as shown in the synthesis of T3 and T4. This inhibits the sodium iodide SYM port located in this region, inhibiting the iodide uptake in the cell. Other medications such as methimazole or propylthiouracil are used to inhibit another part of the pathway as shown here. This inhibits the thyroid peroxidase and again inhibits any production of thyroid hormones. Patients then put on long-term surveillance plan to be able to monitor their hormone and electrolyte levels. To discuss our patient now, I'd like to walk through the preoperative, intraoperative, and postoperative management of our patient. Our patient was then referred to an endocrine surgeon who performed another ultrasound. This again showed bilateral enlargement of the thyroid with microcalcifications or Samoma bodies. Also, this showed that there are multiple enlarged lymph nodes on the central and lateral lymph nodes. These lateral lymph nodes are located along the internal jugular veins. It's important to note that with our patient's cancer, that up to 40% of the lymph nodes removed are typically cancerous or affected by the cancer. An MRI was not performed, although some may argue that any retropharyngeal lymph nodes may be visualized. And a CT was not performed, as the contrast typically given with a CT may interfere with the radioiodine ablation soon coming to the patient. A fiber optic laryngoscopy was also not performed, as our patient showed no dysphonia or voice changes. The surgical plan for our patient was indicated for a total thyroidectomy, which is indicated for papillary cancers greater than 1 to 1.5 centimeters. This is according to the American Thyroid Association guidelines. With any surgery comes risk, and ours is no different. The major risk for our surgery is the risk of developing hypoparathyroidism, or low PTH levels. This occurs due to the location of the parathyroid glands as shown in this figure. These are located on the posterior aspect of the thyroid and are small and often hard to differentiate between what is parathyroid gland and what is thyroid gland as they remove the thyroid gland. This occurs as a temporary hypoparathyroidism in 20% of cases, typically resolving within 6 months. This may also occur as a permanent damage in 2% of cases, or no function is retained. The second major risk that we see with this surgery is the risk of recurrent laryngeal nerve palsy. This is again due to the location of the recurrent laryngeal nerves located here in our figure, as these rotate around and extend superiorly to the inferior portion of the thyroid. This palsy may occur unilaterally 5% of cases and bilaterally 1 to 7% of cases, depending on the physician's experience level. I would now like to talk through the steps of our surgery. It was first started with electrical monitoring of the recurrent laryngeal nerve via the endotracheal tube by the anesthesiologist. The surgeon would stimulate the recurrent laryngeal nerve, and the anesthesiologist would visualize the vocal cords to make sure that they're properly intact. The procedure then continued with a total thyroidectomy. This was done after both recurrent laryngeal nerves and both parathyroid glands were identified and put away to be saved for later. The surgeon then resected any affected lymph nodes or suspicious lymph nodes. In our patient, there was many lymph nodes resected. In total, there's 85 lymph nodes removed, 30 of which were actually cancerous. To discuss more of the parathyroid autotransplantation, it's actually one of the few organs to be autotransplanted in the body. And I forgot to mention that these parathyroid hormones were autotransplanted to the sternocleidomastoid muscle, as located here. This is due to the high vascular content of the muscle. With this transplantation, these glands actually become functional after about 2 weeks in 80% of cases that it's done. The next step for our patient was the radioiodine ablation. This was done to obliterate or destroy any residual thyroid tissue, and is due to the unique uptake of iodine into the thyroid tissue. Our patient received 100 millicurie of radioactive iodine. Typical dosing for this is 30 to 100. The lower dose of 30 is for pediatric patients or patients in renal insufficiency. The higher dose is for adults or patients who have extensive disease. As we see, although our patient is a pediatric patient, she received the higher dose due to her adult stature and her extensive nature of her disease. For this ablation to be effective, it requires high levels of thyroid-stimulating hormone, or TSH. This is due to TSH being required for the uptake of iodine to the thyroid tissue. This can be accomplished by 2 methods. The first method is simply giving more recombinant TSH or synthetic TSH. The second method is interesting in that it's done by the withdrawal of the thyroid hormone. As seen in this figure, the negative feedback loop, as we remove T3 and T4, it no longer has the ability to inhibit the anterior pituitary to raise your levels of TSH, effectively raising your thyroid-stimulating hormone levels. As this method is shown to be more effective, it was used for our patient. These are typical radio-labeled iodine full-body scans of a patient. To note, this is not scans from our patient, but are used for demonstration purposes only. As we see here, with the head being located here and the torso down here, we see that the iodine is taken up in the neck or in the thyroid gland. This is before the ablation. After the ablation, we see that these marks go away, showing the efficiency of our radioiodine ablation. After the surgery and after her ablation, our patient was then put on a strict surveillance and maintenance program. This started with a neck ultrasound, which is your gold standard for cancer surveillance due to its sensitivity. Our patient then also received a chest CT, as our patient's cancer has a typical metastatic path to the lungs. Both the ultrasound and the CT were clean, showing no cancer. Our patient was then monitored for anti-thyroid globulin antibody levels and her thyroid globulin levels, as these were significantly elevated before her procedures. Next, our patient was given high doses of calcitriol, or activated vitamin D, to help with the calcium balance in the body. As noted previously, one risk or one side effect would be hypoparathyroidism from the procedure. Parathyroid hormone works usually by raising the calcium levels in the body. Calcitriol, or formerly also known as 1,25-dihydroxycholecalciferol, works by raising the calcium levels in the body through the absorption of calcium from the gut and the absorption of calcium from the gut and resorption of calcium from the bone. This effectively raises our calcium levels and hopefully alleviates our risk from hypoparathyroidism. The outcome from our patient was great. 15 months after these procedures, her globulin levels returned to normal, as shown. There is no evidence of cancer on ultrasound or radioactive iodine scans. Furthermore, 2 years after her procedures, she is asymptomatic with normal calcium and parathyroid hormone levels. To note that levothyroxine, or the synthetic thyroid hormone replacement, is a treatment given for life. Osteopathic treatments are contraindicated for our patient due to her previous history of cancer and risk of metastasis. For our emerging research for thyroid cancer, there are new molecular testing panels that can identify the specific kind of thyroid cancer. In our patient, who had papillary carcinoma, the common mutation would be in the BRAF gene. This is a mutation from position 600 valine to glutamic acid. And as shown in this pathway, not to get into too much depth, as we upregulate the BRAF gene, this increases the MAP kinase pathway, which then leads to further cell proliferation or the risk of cancer. Also with emerging research was noted that our patient developed Hashimoto-like symptoms. This may actually be a risk factor for papillary carcinoma and is the common thought, however, it's not been proven. In our bioethical considerations, our patient is a pediatric patient, so parental consent needed to be obtained. Our patient also received some adult treatments or medications or dosings, and so is unsure whether she was treated as an adult or child throughout her stay. Also, it's important to look at the molecular testing as a way to eliminate any need to rebiopsy from inconclusive results from refined needle aspiration. In our patient education, because our patient had cancer, the staging and prognosis for cancer needed to be verbalized, as our patient had stage 1 papillary thyroid cancer, which has a near 100 5-year relative survival rate. Also, the risk of surgery were explained, and also with our patient's levothyroxine treatment that needs to be taken daily, it's important to explain that strict compliance is needed. Here are our references from our case study today. We'd like to thank our KCU faculty for their advice and support and counsel during our presentation. Thank you for your time. We'd like to have questions.
Well, I know you've got some questions, so who wants to start first? Down here. Yeah. You want to use that mic? Yeah.
So one of the questions that we received were, are there genetic markers that are associated with papillary carcinoma? And as discussed, the BRAF gene is associated with papillary carcinoma. A mutation in the BRAF gene would cause a shift from valine to glutamic acid at position 600, causing a upregulation of the pathway, specifically the RAS-RAF MAP kinase pathway, and cell proliferation.
Other questions?
So we got a question that asked, what do hyperechoic foci mean or indicate in the ultrasound? And hyperechoic foci are just non-specific. It's just a non-specific finding that means you have a mass within whatever tissue that you're looking at. And so you need to do more detailed imaging, either MRI or CT, or you can do something like final aspiration, which we mentioned in the presentation, which helps you get a more detailed look at the hyperechoic foci.
They are images that appear with more of a reflective pattern, so to speak, when you do the ultrasound. That's why they're called hyperechoic.
Another question we got was asking if there's a role for cytomel being used in the healing of hypothyroiditis or hypothyroidism. Cytomel is a synthetic T3 that is typically used in the treatment of hypothyroidism or also to suppress TSH in the treatment of hyperthyroidism. However, excuse me, levothyroxine is generally considered the most appropriate thyroid replacement agent for people that have long-term hypothyroidism.
Cytomel is an old drug, dates way back, and it's not considered the standard of care today as in the past.
Another question that we got was initial labs showed normal T3 and T4, but increased thyrotropin. Why? Thyrotropin is also known as TSH, or thyroid stimulating hormone. It binds to the TSH receptor on the thyroid gland to cause trophic effects as well as thyroid hormone production. As we know that the antibodies that we found bound to thyroglobulin as well as the thyroid peroxidase, causing decreased thyroid hormone, but we believe that the increased TSH normalized these T3 levels.
Other questions?
Yeah, so we got a question that said, what type of viruses can cause thyroid pathologies? And so literally just found that thyroiditis is a rare condition, but you can get viral infections that cause infection of the upper respiratory tract, such as mumps, influenza, or the common cold. So those kind of viruses can lead to thyroid inducing pathologies.
Right here.
The question is, what types of foods are goitrogens? The types of foods that we mentioned during the presentation were cassava, millets, and kelp. Additionally, cruciferous vegetables can be considered goitrogenic as well. But the most common goitrogen ingested by children is iodine, and it typically does not cause a problem unless the thyroid function is decreased. And in that case, the thyroid has a hard time keeping up with the iodine uptake and causes goitrogen or goiter.
One of the other questions we have is, what is exophthalmos? It's an abnormal protrusion of the eyeball due to accumulation of connective tissue from the prostaglandin infiltration, and is usually associated with Graves' disease, and is also can caused by trauma, vascular issues, or neoplastic syndromes as well.
Are there other questions? I see our pediatrician here, and we'll yield to Dr. Newman.
I just wanted to say, I've heard lots of presentations on thyroid disease in kids, and you could trot this presentation to any children's hospital and compete with the residents that are making a presentation. This was an excellent presentation. Yeah.
That calls for a little applause. Thanks, Ray.
I just wanted to say just a couple things. Whenever you are considering, or if you suspect thyroid disease, or when to suspect thyroid disease in kids, if you have a family that has a big autoimmune history, a family that has lots of autoimmune diseases, always keep your ears perked up for thyroid disease. It's not common in kids, but it can happen. The being aware of thyroid disorders has to start when a baby is first born, and I wanted to remind everyone that tests for thyroid and hypothyroidism are included in newborn screens that are done on every baby in every state and the 2 territories in our country. So you have that information from the get-go. And just one more thing, no Samoma bodies. They will occur or rear their ugly head in your future. And if you are a pediatrician or if you are a family practitioner in a busy practice, you will see, you will either take care of or diagnose someone with hypothyroidism. and you will see or take care of someone that has a thyroglossal duct cyst. So, so this is a really important topic. But again, you guys did a great job. So.
Dr. Newman, thank you. This case illustrates, I'm just going to ask you a couple other comments to be thinking about before we conclude. I want you to leave your classmates with a take-home message, and I'd like for you to be able to come up with 3 take-home messages for a case like this. I thought your presentation, I would echo what Dr. Newman says, I thought your history and the progressive line as you told that story was very appropriate and well done. I thought that your differential diagnosis you're very knowledgeable of that, and you selectively excluded those and explained those with clarity. I thought that your treatment was well explained with the drugs, particularly where the drugs work, how they work, and what you should monitor as you're treating these patients. Having said that, if you were to give your audience and folks at home a take-home message, what would that take-home message be after you've studied? And I will say this, a lot of this depth of knowledge is self-acquired. This is tapping into resources that are available from the medical informatics course, but the faculty does guide and helps, but they are self-taught in this exercise. So, in short, what are some take-home messages that you would like to disseminate?
Among the ones we came up with, we felt that one of the most important ones was compliance of the levothyroxine treatment. Some of the factors that you need to think about are you need to drink an 8-ounce glass of water 30 minutes before a meal, usually in the morning, on an empty stomach. Or if you have other medications, you need 4 hours prior to that list of medications.
The importance of correctly running through the differential diagnosis and finding why, one way or what's wrong or one of the reasons is not wrong or what's wrong with the patient. Sorry, and correctly finding what's wrong with the patient and treating that.
Clarity of differential diagnosis.
And then obviously early detection is key. She presented earlier on, and then later, 15 days later, went to the endocrinology clinic. And in doing so, they were able to find these bodies and, run through the differentials, as we mentioned earlier. So early detection is key in order to be able to treat a disease such as this.
I think Dr. Newman's comments relevant to the rapid growth, the strong familial history, and mother's index of suspicion that something was wrong helped to solidify that something needed to be done. We want to thank you. Good job. Give it up, and we'll have the next group come in.
Hello? Oh, okay. Okay. Good morning, and thank you for joining us today. My name is student Dr. Jaldi Patel, and our group will begin by presenting the case of a 40-year-old pregnant woman with placenta accreta who declined blood products. These are the members of Group 20, and I will begin the clinical presentation of this case. Our patient is a 40-year-old woman who presents to the office at 12 weeks and 1-day gestation for her first prenatal checkup and to receive prenatal care at the health center. This patient is gravida 5, para 4. Gravida 5 means that she has been pregnant 5 times, with this pregnancy being the 5th, and para 4 means that she has delivered 4 times. She has had normal vaginal deliveries with her first 2 pregnancies 16 and 9 years ago. For her later 2 pregnancies, she had 2 cesarean sections for breech presentations 7 and 5 years ago. When reviewing her past medical history, she had a positive TB skin test with a clear chest x-ray in 2003. This was treated with isoniazid for 6 months. She also had a history of iron deficiency anemia and used to take iron supplements, but discontinued these due to her GI intolerance. She is also varicella-zoster immune and positive for rubella antibodies. These are both good things, as if she were to get these diseases during her pregnancy, it would negatively affect the fetus development. In the case of obtaining varicella-zoster, the fetus would be at a greater likelihood of obtaining congenital varicella syndrome, and in the case of rubella, the fetus would be at greater risk for obtaining eye, ear, and heart damage. She has a past surgical history of 2 cesarean sections in 2004 and 2006. She also has no known food or drug allergies. She is not taking any medications, but is currently taking a daily multivitamin. This patient was born in a Caribbean country and currently lives with her husband and children. She works in the healthcare field along with her husband. She denies the use of any alcohol, smoking, or illicit drugs. She is also practicing practicing the faith of Jehovah's Witness. This is extremely important in our case, as her religious beliefs will prevent her from accepting any blood products for medical treatments. For her family history, her father passed at 70 years of age and had a medical history of hypertension and epilepsy. Her mother is alive and has a history of hypertension. Her sister carries a sickle cell trait, and her children are all alive and healthy. From the tests done during her initial prenatal visit, her lab results were her weighing in at 60.3, her blood pressure being 100/58, her hematocrit was 29.1, and hemoglobin was 10.1. Compared to the normal values for pregnant women, these values are lower, however, this is consistent with her history of iron deficiency anemia, as she will have increased iron demands and blood volume expansion during her first and second trimester. Her blood type is type O, which is the blood type of being a universal donor, and she is also rhesus positive. During the initial visit, another cesarean section was advised, and an iron supplement was prescribed for her history of iron deficiency anemia. 8 days later, at 13 weeks and 2 days gestation, a transvaginal ultrasound of the patient's pelvis showed a single active fetus with normal heart rate. The placenta was forming posteriorly, and the amniotic fluid volume and adnexa were normal. At the patient's second trimester examination at 20 weeks and 6 days gestation, a repeat ultrasound was ordered. In the sample normal ultrasound on the left, the placenta can be seen here as a complete gray structure lying on top of the myometrium. As a reference, for a patient's ultrasound,
The fetus's head is located on the left, the placenta in the middle, and the free fluid on the right. The ultrasound taken of the patient reveals a single active fetus, right lateral placenta previa, and increased flow in the anterior lower uterine segment. This arrow shows the placenta is overlying the internal cervical os, in addition to depicting the invasion of the myometrium, which can be seen by this thin white area surrounding the darker echolucencies in the ultrasound. These features are all suggestive of placenta accreta. I will now turn over the floor to student Dr. Papandreou to present the differential diagnosis.
Thank you, student Dr. Patel. I'm student Dr. Stefan Papandreou, and I'll be discussing the differential diagnosis for our case. Here's the ultrasound at 20 weeks and 6 days was suggestive of placenta previa with risk of placenta accreta. Placenta previa is a condition in which the placenta is inserted partially or wholly in the lower uterine segment. It can cause complications with delivery requiring C-section as well as vaginal bleeding. It is a major risk factor for placenta accreta. Other risk factors include maternal age greater than 35, previous C-sections, hypertension, and smoking. This image shows the 3 different types of placenta previa characterized by the level at which the placenta is blocking the cervical os. Shown here is marginal placenta previa, where the placenta is near the edge of the cervix. In partial placenta previa, it is partially covering the cervical os. And in total placental previa, the placenta completely covers the cervix. Vaginal delivery is still possible with partial and marginal placenta previa, but with total placenta previa, a C-section is required. This chart estimates the increased risk of placenta accreta in patients with and without a placenta previa diagnosis. Our patient, who had 2 previous C-sections as well as placenta previa, is at an initial risk of 40% of placenta accreta. With the patient's age and previous C-sections, as well as the ultrasound findings in the 2nd trimester showing large echolucencies in the stroma of the placenta, loss of normal hypoechoic myometrial band beneath the placenta, and increased vascularity around the lower uterine segment, our case-based estimated risk in our patient is around 60% of placenta accreta. Placenta accreta, along with placenta increta and placenta percreta, are all findings consistent with abnormal placental attachment. Placenta accreta is characterized by trophoblastic invasion to the level of the myometrium. Placenta increta is trophoblastic invasion into the myometrium, and placenta percreta is trophoblastic invasion through the myometrium, through the serosa, and into the extrauterine space. This image shows the trophoblastic invasion of the placenta to the level of the myometrium with placenta accreta, into the myometrium with placenta increta, and through the myometrium and the serosa in placenta percreta into the extrauterine space. Complications arise in patients with abnormal placental attachment due to the damage caused by detachment of the placenta from the uterus. This can damage the local extrauterine organs in placenta percreta only, and can also cause life-threatening hemorrhage. All 3 can cause life-threatening hemorrhage requiring transfusions and hysterectomy, postoperative bleeding or thromboembolism, complications with blood transfusions, assisted ventilation, and death. Ultrasound at 27 weeks confirmed a complete placenta previa with sonographic findings consistent with placenta accreta. Our patient was made aware of the risks associated with the condition but will refuse all blood transfusions. Goal is to optimize iron content and minimize blood loss, and we will perform C-section and hysterectomy at time of delivery. Methods for minimizing blood loss preoperatively include iron supplementation and pharmacological stimulation of erythropoiesis. Intraoperative includes autologous blood donation, acute intraoperative hemodilution, cell saver technology, and balloons for intravascular occlusion. We will discuss which methods were used in our patient and which were contraindicated. In week 27, labs show mild anemia, hemoglobin at 10.1, hematocrit at 29.1%. At week 28, the patient was placed on iron supplementation, 15 milligrams iron polysaccharide twice daily. And at week 30, she was placed on 300 micrograms per milliliter darbepoetin alpha administered every 2 weeks, which is a pharmacological stimulator of erythropoiesis. The patient was admitted for delivery by C-section and hysterectomy at week 36, just prior to a full-term pregnancy. Methods not used to minimize blood loss include autologous blood donation, where the patient donates her own blood prior to a scheduled operation in order to be transfused when needed. The pros of this method are that blood will always be a match and there will be no risk of contracting diseases such as hepatitis or HIV and no risk of an allergic reaction. This was not applicable in our patient, though, due to her anemia. Also, acute intraoperative hemodilution, a blood conservation technique that entails removal of blood from a patient shortly after induction of anesthesia with maintenance of normal volemic status using crystalloid or colloid replacement, was also not used due to her anemia. Methods that were used intraoperatively include cell saver technology, where blood is drawn using a vacuum source from the operative field, where it is centrifuged and washed to remove the red blood cells, or to collect the red blood cells and remove any waste, including anaphylotoxins, activated cytokines, and other waste products. Blood is then retransfused into the patient. Venous blood can also be drawn, and using a membrane oxygenator, the red blood cells can be oxygenated and retransfused, only this was not utilized in our patient. Balloons for intravascular occlusion are used to control intraoperative bleeding. Balloons were inserted into the internal iliac arteries and inflated in order to reduce blood flow to the area. At 36 weeks, a female infant was delivered by C-section. She weighed 2.5 kilograms, consistent with her slightly premature birth. APGAR score at 1 minute was 4, but APGAR score rose to 8 at 5 minutes. Here's a typical APGAR scoring chart, named after Dr. Virginia Apgar, who invented this method of assessing the health of a newborn in 1952. Appearance, pulse, grimace, activity, and respirations are graded from 0 to 2 and added up. A score of 7 to 10 is considered normal, though a score of 10 is rare. A score of 4 to 7 may require some resuscitative techniques, and a score less than 3 requires immediate resuscitation. Postoperatively, the patient was transferred to the ICU following hysterectomy. 3 liters of blood were lost, 1.1 liter returned through cell saver technology. Patient was transferred to the surgical intensive care unit where the trachea was extubated the following day. Postoperative 1-day blood values, hematocrit was 26.4%, hemoglobin 9.3. A gravid hysterectomy specimen was received in the pathology department and shows the placenta strongly adherent to the lower uterine segment, consistent with total placental previa. I'll now present student Dr. Ride Pandya for the ethical and legal considerations.
My name is student Dr. Ride Pandya, and I will be discussing the ethical and legal considerations in this case. Religious and cultural context plays a large role in this case in which the patient has refused a blood transfusion. It is important to understand why patients of certain cultures and faiths refuse blood transfusions. The patient in the case at hand is a practicing Jehovah's Witness. Jehovah's Witnesses follow what is called the Watchtower blood doctrine. They believe that blood is sacred, and as a result of this belief, blood transfusions are forbidden. It is their belief that receiving blood blocks passage into heaven, and accepting blood may also result in rejection and exclusion from the social or religious community. While religion plays an important factor in the patient's decision and needs to be taken into account, ethics plays a large role in this case as well. The 4 principles of bioethics are respect for autonomy, non-maleficence, beneficence, and justice. In the context of our case, respect for autonomy would mean that the patient is involved in making an informed and voluntary decision. Non-maleficence would mean that no intentional harm or injury would be created to the patient, either through acts of commission or of omission. Beneficence would mean that the healthcare provider has a duty to be of benefit to the patient and take steps to prevent or remove harm from the patient. And finally, justice would mean fair distribution of resources for all patients and treating like cases alike. For the purposes of the present case, we will be discussing the principles of autonomy and justice. Respect for autonomy for the patient means that the patient has the capacity to act intentionally, with understanding, and without controlling influences that would reduce the patient's ability to make a free and voluntary judgment. This requires informed consent. In order for the patient to have been informed, it is first necessary that the patient be competent. The patient must be able to recognize that there is a decision to be made, understand the information needed to make the decision, understand the treatments, understand the risks and benefits, and also use the information to come to a decision. In addition, in order for the patient to be truly informed, they must be allowed to ask questions and be provided full disclosure. After having been informed, the patient has to provide consent. As mentioned earlier, this requires that the patient be competent and capable of making a decision. The patient must also be free from any coercion or manipulation while being fully alert, aware, and oriented. In this case, the patient declined blood products despite knowing the risks involved with doing so. In addition to the patient's autonomy, the physician's autonomy must also be considered. Physicians have a duty to their patient, and as a result, they cannot abandon the patient or deny them alternative methods of care. Even if there may have been a conflict of beliefs between the physician and the patient, the physician must be able to provide all the information necessary in regards to alternative treatments and must do so without coercing the patient to make a particular decision. If the physician is not comfortable with the situation, refusal of care is allowed, provided that another provider be guaranteed to the patient. This was not necessary in the case at hand. The second principle of bioethics we'll be discussing is that of justice. This entails the need to treat like cases and patients alike. In the context of the present case, the issue of allocation of resources arises. By denying blood products, a greater amount of time, assets, equipment, and specialists and physicians were necessary in order to treat the patient. There were uncommon procedures performed on this patient's C-section. Over 10 multidisciplinary teams of specialists were called upon to help the patient. The patient received expensive and limited resources that could have been provided to other patients had the patient accepted the blood products. In addition to the ethical considerations of the case, there are several legal considerations that must be made as well. This is an example of an advanced healthcare directive. Our patient has indicated that she does not want a blood transfusion on a directive like this one. This is important because it means that the patient has provided a statement of refusal for a blood transfusion. As a result, the providers are protected from any legal ramifications that the denial of blood products may cause in the outcome for the patient. While this is true, the providers must still provide all the information necessary in regards to alternative treatments and must do so without coercing the patient to make a particular decision. In addition, it's important to note that in most states, a spouse cannot override a patient's decision on whether or not a patient should receive a transfusion. The only exception is if the patient lacks capacity. In some states, however, there is precedence that allows a hospital to force a patient to accept a blood transfusion if there is no other caregiver for the child. That is to say, if the fetus were to be orphaned should the patient not survive the delivery, the patient can be forced into accepting the transfusion. Different states have passed different legislation on this matter. There have not been many specific situations that have been brought to the court that can be applied to the case at hand, and unfortunately, none of the relevant cases occurred in Massachusetts, which is where our patient is being treated. However, some of the precedents that has been set in other states can be applied to this case. There are two similar cases that we will be discussing today. The first case we would like to look at is that of Patricia DeBruyle, and the second is that of Fetus Brown. Mrs. DeBruyle was a pregnant female who was brought to a hospital in Florida. She was in late-stage pregnancy, but under non-emergency conditions. She had had 3 children previously. After being admitted to the hospital, she consented to a C-section, however withheld consent for a blood transfusion on the basis of her religious beliefs. Like the patient in our case, Mrs. DeBruyle was a practicing Jehovah's Witness. The hospital, out of concern for Mrs. DeBruyle's life, contacted her estranged husband who had agreed to the blood transfusion. The court ruled with the patient on the basis of no abandonment issues towards the children. In other words, due to the fact that the fetus was in no physical danger and there was someone to take care of the child if something happened to Mrs. Debreuil during the delivery, the patient should have been able to make an autonomous decision for herself. This is also the circumstance of the patient in our present situation. The fetus is not in danger, and there is a spouse that can take care of the child if something were to happen to the patient during the delivery. As a result, the patient should be allowed to make an autonomous decision for herself, and the blood products should not be given to her. Another case involved a 34-week pregnant woman named Darlene Brown, who is admitted to a hospital in Illinois. A surgery for the removal of her urethral mass was performed, in which she lost 1,500 cc's of blood, which resulted in the need for a blood transfusion. Her hemoglobin fell to less than 1/3 of the normal value for women at her stage of pregnancy. The patient, who was conscious during the procedure, denied the transfusion on the basis of her religious beliefs as a practicing Jehovah's Witness. In her case, there was significant harm that might occur to the fetus. Without a transfusion, the fetus had a 5% likelihood of survival. A transfusion was the only way to get oxygen through the placenta to the fetus. As a result, the physician who was caring for Mrs. Brown at the time ordered the hospital to obtain temporary custody of the fetus. The court ruled in favor of the hospital, and the blood transfusion was completed. After a healthy delivery, Mrs. Brown appealed to the Illinois Supreme Court, contending that under federal and Illinois law, she had the right as a competent adult to refuse medical treatment. The Supreme Court ruled in favor of Mrs. Brown on the basis that her autonomy did not diminish during the pregnancy. In Mrs. Brown's case, her autonomy did not diminish despite the harm that would potentially have resulted to the fetus. In other states, such a harm would allow the hospital to mandate a patient to accept blood products. In the present case we are discussing today, the fetus is not being harmed by the decision to deny blood products, and there is no legal precedence that would diminish our patient's autonomy in such a case. As a result of this, we conclude that legally, the patient is able to refuse the transfusion. In regards to osteopathic manipulative medicine, muscle energy and high-velocity, low-amplitude techniques are contraindicated for this patient. This is because our patient has a history of anemia and has refused to accept blood products. Due to the complications and the risk of hemorrhage and the fact that she is in the 3rd trimester of pregnancy, OMM is not indicated. If necessary, soft tissue and myofascial release techniques may be used for the limbs and other areas distal to the lower lumbar region to avoid any risk of complications with the pregnancy. This concludes our presentation for today, and we will now open it up for questions. Thank you.
Okay, I'm sure you've got some questions, so which side would like to start first? Down here.
So the first question that we had was this patient vaccinated against TB in her life? And after reviewing the article, we couldn't find anything that said whether or not she had been vaccinated. It simply just said that she had had TB about 8 years ago and took isoniazid for it for about 6 months afterwards.
The fact that she came from the Caribbean may have some implication for a BCG vaccine. It's very frequently some people will react in a false positive manner. This patient received INH for 6 months. Whether or not, and I'm not looking back, whether or not she needed it or not, tough to say. But there's other tests that you can implement to confirm whether or not she's got tuberculosis.
Does this work? Okay. So the next question is, what is the usual dose or schedule for oral ferrous sulfate, and any tips on how you can facilitate absorption? So dosing cycles are normally recommended based on your daily dose as well as how much deficit you have. And the normal dosage daily is 300 to 325 milligrams, as well as up to 5,000 milligrams of oral elemental iron per month. And then it's best absorbed on an empty stomach. However, in the case of our patient, it can also be taken with food if you have GI intolerance.
Is it working? Okay, cool. So our question was, why was a C-section advised at first visit? Because a lot of docs do VBACs, and it's because she had a past history of having babies with breech presentation, so the feet and bottom was closest to the cervix, and vaginal delivery is possible, but there are better outcomes usually if you do a C-section, so it was just preparing her for the possibility of a C-section if there would be a breech presentation.
The next question is with regards to the rhesus blood group system, and it asks, what are the main antigens and which antigens make you Rh positive? So the Rh factor, which was named so after being discovered on rhesus monkey, is a type of blood protein found on the surface of red blood cells along with A, B, and O blood types that further specify what type of blood the patient has or the person has. And if an individual has the rhesus factor, they would be deemed Rh positive. As it pertains to our case, the mother was Rh positive, meaning she possessed the rhesus antigens on her blood cells, and usually there's no complication in this instance. However, if the mother were Rh negative and the baby was Rh positive, mixing of their blood would lead to an allergic reaction by the mother's antibodies, and to prevent this, a rhesus immunoglobulin injection can be done. But in this case, the mother being an Rh negative mother was not an issue.
I think we have one down here.
I'll go ahead.
Oh, go ahead.
So the question is, what blood products can a Jehovah's Witness patient receive? So they'll refuse all whole blood donations, so red cells, platelets, white cells, but depending on how strong their faith is, some of them will accept derivatives of primary blood components such as albumin, clotting factors, and then erythropoiesis stimulating factors as well.
Okay, after that question, Dr. Hubbard, hematologist, do you have any comments relevant to other blood products that the Jehovah's Witness could receive that wouldn't, that the community may not have some issues with, I should say? There you go.
Thanks, Dr. J. Yeah, great question and great presentation, guys. There's a couple of things that I think are important to make as preference comments to Dr. J's question. The first is that one of the things that we do in medicine all too commonly is we make a flaw in our logic. And our flaw in our logic is that we say that if a patient is, and we'll use the typical terms that we all learned in Logic 101 in undergrad, if the patient is P, then the patient will choose Q. Okay? What that does is it takes away the patient's autonomy. It takes away their right to make their own free decision. All of us are individuals, and so it's important as physicians that we not paint with too broad a brush. Experience has taught me that with respect to Jehovah's Witnesses, there are many things that they will step up and categorically decline on the basis of their faith. But I always ask them because I want to make sure that I understand their own personal request. Secondly, there are variabilities in how they will apply their faith. And one of the questions that I asked was, would a Jehovah's Witness accept blood back from a cell saver? So if you haven't seen a cell saver before, just imagine something that kind of looks like a little vacuum. It kind of sits at the corner of the surgical field, sucks up the blood, and then returns it back to the circulation. My experience with that is it depends. It depends on the individual. Some of them will. And what I've learned is that usually it's people who are a little bit closer to healthcare are willing to consider that. Jehovah's Witnesses who are not really tied to healthcare, they really represent the lay Jehovah's Witness population, may be very opposed to that. So it's important to take it on an individual basis. Other blood products, they will oftentimes interpret that variably, and so the comments that you make are appropriate. Albumin, I think, has been considered, they've been rather concerned about that, but in Jehovah's Witnesses who have hemophilia, they have been willing to accept recombinant factor concentrates to replace for bleeds. So these are genetically derived, and they're safe. There's no risk of hepatitis or HIV with these, and they've been open to receiving those. Now that, of course, is a lifelong process in the case of patients with severe hemophilia. Thank you.
Thank you, sir. On that same line, I saw Dr. Brett Johnson. Brett, where are you? Brett, do you have any other comments that you'd like to make relevant to some ethical issues in this particular case? Before this is addressed, this lady was lucky. She didn't need anything. Unfortunately, she came in with marginally low, but she went out with acceptable low after the C-section. So we were fortunate that she didn't require any supplemental blood products. Go ahead, Brett. Dr. Johnson is one of our bioethicists here, so I'll yield to her. And also a lawyer, or law trained.
You know I don't like it when people find that out about me. First of all, excellent job. This is a really complex case on a lot of levels, both medically and ethically and legally. You did a really nice job drawing out the points of each and how sometimes they conflict and sometimes they work together very nicely. So in this case in particular, in Massachusetts, some of the legal implications were that there might have been a little more legal leeway to follow what the patient particularly was requesting. And at this institution that had the resources available to meet her needs along with her requests, you were able to have a really successful outcome, and you were able to plan far enough in advance to ensure that that happened. In other states, Florida, Illinois, as you pointed out, there might be other legal considerations that might have made that more complex for our particular patient to make the decisions and have the physicians respect the decisions she was making. So sometimes what's medically indicated is not what's accepted by the patient, and sometimes what's ethically indicated for the patient and the physician is not what's legally acceptable in the state. So it's good, especially in a case like this when you can, to negotiate all of that long in advance and know exactly what you're dealing with and get all of the help and resources you need to make those decisions. It's a lot more complicated if this patient, for instance, had shown up in the ER in the middle of delivery denying blood products and no one had discussed it in advance. Then you have a much more complicated, messy case.
Thank you, Dr. Johnson. Did you have a question, Doc?
It was about the cell saver.
Cell saver's been answered. And I think we got one last late question that was submitted. We have it.
So the last question was, would the presence of relaxin during pregnancy contribute to OMM contraindications? So what we found was that during pregnancy, progesterone and relaxin are secreted, and they contribute to relaxing the ligaments. However, it also adds extra pelvic pressure. So we believe it would be an OMM contraindication.
Okay. Before we conclude this, again, I want you to come up with 3 take-home messages for your colleagues. And I want to compliment you about your presentation. I think there was good clarity of taking the history, showing the good differential diagnosis of how the placenta can lie in utero and the potential complications therein. And then I thought the ethic issue was addressed very well. I think Dr. Hubbard's comments about it's kind of a moving target from one patient to the next, and that has to be taken into account when docs are taking care of patients. So, was there one more question?
Oh, no.
No. Okay. What are 3 take-home messages for your classmates and the audience?
Okay, so I'll start with the first point. And I guess the first big take-home point from our presentation is that as future physicians, we have to respect the patient's autonomy. Despite the fact that our clinical acumen or medical knowledge or experiences may trump the sentimental and religious decisions that patients might make sometimes, we have to abide by the laws and most of all, respect the patient's decision regardless of whether or not we think that is the right decision.
I think that's well said. One of those most important components is what does the law state in what does the law say in your state? That's important. All right, very well said. What else?
Going along with what student Dr. Parks said, medicine is more than just about the pathology and diagnosis. It also involves taking other aspects into account. such as the patient's ethics, background, religion, and other aspects of their life.
All right, and for the last one, we kind of touched on this earlier, but don't paint every patient with the broad brush. So if they say they're Jehovah's Witness, you don't know what level they're willing to accept blood products or what they want to do with their treatment plan. So make sure you include the patient as part of the treatment plan.
Very good. Let's give it up, and thank you very much for your attendance.